I'm Professor Wallace, and I want to welcome you to the International Law Institute. This format is novel. The times are even more so. I don't think that subject could be more timely than this one. And I would like to turn things over to Yona. And again, thank him for assembling a wonderful panel, including Ford Rowan, my old friend. So, Yona, you're on.
Thank you very much, Don. My appreciation, of course, is always to you personally and to the very able staff at the ILI. It's unbelievable that I try to count how many years we try to cooperate academically. It's nearly half a century. I cannot believe it. In fact, last month, we had an event with the ambassador, retired ambassador Stu Eisenstadt, dealing with the global issues in the Middle East, the Carter administration, and so on and so forth. And we're pushing with a number of projects, security through law, the role of diplomacy in world affairs, etc., etc. So it is a pleasure indeed to continue, however modestly, with our academic work. What I would like to do first, very quickly, is to introduce our panels and commentators and audience and all that. Now, obviously, the rationale for having an event titled Combating Global Coronavirus from Isolation to International Cooperation, maybe we should put a question mark there. At any rate, I think in the view of the growing concern of the international community with the various interdisciplinary consequences of the outbreak of the epidemic, I think we will try to focus on both threats and responses, both on the national and the international level. Fortunately, we do have a very distinguished panel of practitioners, academics, of government officials, and so forth. So I would like to introduce them very briefly. Obviously, they have a very rich, distinguished background and history and experience. We're going to include their bios fully in our planned publication, the report. I just would mention one or two highlights. The first one, Dr. Roberta DiBiase, she is the chief of the Division of Pediatric Infectious Diseases of the Children's National Hospital Children Research Institute, as well as a professor at the George Washington University School of Medicine and Health Sciences. And she will begin with the overview and then specifically focus on some of the issues that she would like to mention initially. Then she will have time with the other panelists to expand her insights later on during the Q&A discussion. The next speaker is Dr. James Giordano, who is also professor in the Department of the Biochemistry and so forth at the Georgetown University Medical Center, and also is co-director of a program on global health law and policy and the senior science advisory fellow at the Joint Staff at the Pentagon. The next speaker is going to be Ambassador retired Charles Ray, who was a former Deputy Assistant Secretary of Defense for POW, Missing Personnel Affairs, and a former U.S. Ambassador to Cambodia and Zimbabwe, and he works with our colleagues on the role of diplomacy in world affairs. And then the final panelist is Ford Rowan, who is a board member of the International Dialogue Initiative and chairman of the National Center for Critical Health and Incidents Analysis. Now, we plan to have also Ambassador Simonovic from Croatia, and he actually communicated with me to express actually his regret that he cannot join us given the very extraordinary and unpredictable circumstances. Because number one, as some of you may know, Croatia tragically had a terrible earthquake. They are also trying to combat the virus. And Croatia has now the presidency of the Council of the European Union. They have to deal with many of the same issues, but the ambassador would provide his remarks, papers, so we're going to publish this. Finally, I would like to mention and welcome, of course, our distinguished commentators, those who are willing to call or participate to make or present a question or make some comments and so forth. I will introduce them later on when they will join us. So first, I'm going to ask Roberta to begin the discussion.
Hi, can everyone hear me okay? I don't know if you can hear me. Can someone?
Yes, this is
okay. So if you pull up the slides. So thank you so much for inviting me to be, thank you so much for letting me be part of this discussion today. I think we'll have a lot to talk about as we all bring different perspectives to this worldwide problem. I, as was mentioned, am the Chief of Infectious Diseases at Children's Hospital here in DC, and also Professor of Pediatrics and Immunology, Microbiology, and Tropical Medicine at the George Washington University. So we're quite engaged in the regional as well as the US response, and we have a particular focus on how this impacts the pediatric population and, of course, the families that are associated with pediatric patients. So you can go to the next slide. So I'm going to start with a situation update just so that we can have the beginning of our discussion here in a context, and I'll just show you the latest data both internationally in the States and then globally. So here we have, this was actually as of this morning, I don't know why it says the 24th, but we have 414,000 confirmed cases globally, 18,440 deaths, and a calculated case fatality rate of 4.4% overall. But what you'll notice is if we look at the different regions, whether that be Western Pacific, European, Southeast Asia, Mediterranean, or the Americas or Africa, there's quite a range in the case fatality rate. If we look at China, the rate there was 4% based on all of the data that's available up through today. But you can see there's quite a wide variation. So Germany has the lowest case fatality rate now with 0.7%. The Americas are lower than China at 1.3%, and we'll see how that holds up as things take off in New York City, which is the new epicenter. And then Italy has unfortunately had very high case fatality rate, almost 10% based on the numbers that were reported through today. And some of this is a reflection of the age of the population in each of these regions, but certainly it is also a reflection of how much the healthcare system has to absorb a large surge at one very small time period. And this is, of course, going to be part of our discussion about some of the measures that have been implemented in other countries as well as here. How can we flatten this curve, as people say, so that the the surge and the potential overwhelming of the healthcare system with an influx of critically ill adults can be tampened down. So next slide. So this is just an epidemic curve of confirmed infections worldwide through yesterday, and the WHO, this is WHO data, as was the last slide. The first kind of hump there in orange reflects the China outbreak, which, as you've all heard now, has settled down quite a bit. There have been periods of no new cases, particularly in the epicenter, which is now actually let some folks leave there because of the evidence that things have really gotten under control. And then, though, however, you see the much larger and later epidemic curve, which unfortunately is still on an exponential rise, which reflects the spread to the rest of the world. And in color codes, you see where those regions are. So the largest part of that bar is red, and that's the European region. And the second largest is the Americas, which is directly reflected by what's going on in New York City right now. So you can go to the next slide. Oh, and actually, I don't, on the right there, go back to the other slide, I'm sorry. If you see on the right here, I was just making a point here that in Italy, where their outbreak began certainly sooner than our current New York outbreak, they have had 69,176 cases and 6,820 deaths with the 9 or 10% case fatality rate. The U.S. has had 51,900 cases and a almost tenfold less number of deaths, 673. But we are, in other words, we are far exceeding the number of cases based on the amount of time that they have had ahead of us, and we will certainly surpass the number of cases in the U.S. But for now, our rate of death, or our case fatality rate, seems to be approximately 10% lower than what's being seen in 8% lower than what's being seen in Italy. And we'll have to see as our healthcare system potentially hits that surge and is potentially overwhelmed, if our case fatality rate will be maintained at this lower rate or not. Okay, next slide. So these are just comparisons of case and death trends across countries that are currently the most active. So in red, so on the left you can see cases, and in red you can see the United States, and you can see that's a 36% rate of growth on this logarithmic scale. So things are definitely very much accelerating in the US, particularly New York. And that is compared to Italy, which is shown in purple, which is certainly also accelerating, but at a slower rate, so 19%. And that is reflected by the fact that they're on day 25 of their outbreak, whereas we in red are around 10 to 15. And China has flattened out, as I said, that seems to have improved. And if you go on the right side, those are death rates. And again, it reflects a similar trend, with the only difference being that the death rate is higher than the actual case rate, the rate of acceleration in Italy, compared to the United States, where the death rate is growing less than the total number of cases. Okay, next slide. This is the United States update as of today, this morning, and these are coded by color based on the density of infections. The states that are in orange are considered areas where there's more widespread transmission and higher numbers of cases, and red is New York, which, as we all know, is much higher than any of these. But the important point here is each day there are more and more cases, or more and more states in the United States that are designated with accelerating numbers of cases. And in particular in the news, Louisiana has emerged as one of the fastest growing problem areas. Next. So this is just a graphical representation of that same data. And in red, you see the cumulative number of cases over the whole period of March. In blue, the blue line, you see the daily new number of cases. So that's sort of the rate of new cases as they accumulate. And in green, you see the number of hospitalized cases. And again, we're on this exponential curve. On the right is a graphic representation of the age of the patients. So as has been appreciated really everywhere in the world, and not different than, this has been seen, the same exact pattern has been seen in every country where there has been affected problems, including the epidemic areas like New York. that we see a peak of both infections but also severe infections in the 60 to 80 year group, and then a much higher mortality in our over 85 to 90-year-old group. And most importantly, this slide does not even list those under 20, but in the large series of Chinese data as well as data that's come out of the United States, it seems that about 2% or less of hospitalized and severe cases are in the pediatric population. So we'll come back to that later, but this gives you the worldwide curve. Next slide. So again, this is just similar data for New York, and it just shows you how steep that rate of rise is for cumulative cases, new cases, and hospitalized cases. And the point I wanted to make here, for those of us that are following how this is starting to develop in different areas of the United States, we actually had Washington State and California as our first areas where there was significant transmission. And these are still considered areas where, for instance, there's extra governmental assistance and provisions being provided to these three areas, Washington, California, and New York. But if you look at the sheer volume of cases, hospitalizations, and deaths in New York compared to Washington and California, again, it's a tenfold difference. So even though it started in California and Washington even, several weeks ago, New York is at 33,000 cases, California is at still around 3,000, and Washington at 2,600. So I think we just have to really appreciate how severe the situation is in New York and how rapidly it's accelerating. And that's a 30%, these rates, they're basically increasing by 30% each day, the number of cases. Okay, next slide. So regionally, we keep a very close eye on this. We work with our regional partners for our emergency preparedness all the time, and for any emerging infectious diseases, we have a very close relationship. But in particular for this current pandemic, we keep a close eye on these numbers, and we work together regionally to think about how we're going to care for a surge of patients. So in the region which we define as District of Columbia, Maryland, and Virginia, we've now passed the 1,000 mark. So we have 1,056 as our number of confirmed cases, and that's about a 20% increase from yesterday. So that gives you an idea of how it's accelerating. We have 135 hospitalized in our region, again, about a 20% increase from yesterday, and then 20 deaths, which are distributed amongst District of Columbia, Maryland, and Virginia. Next slide. And this again is a similar graph that just again shows you that we are not immune to what's going on in the rest of the country here in the DC metro regional area. So very similar slope of the curve for increase of cases. Next slide. And that actually may be it. So, I'm going to just end by just talking a little bit about Children's Hospital. And I didn't put up slides here, but we have been preparing for really since January for how this might impact the pediatric population when we first heard of the cases coming out of China. And I should preface that by saying at Children's, we have a long history of not only disaster preparedness, but emerging infectious diseases expertise and preparedness. We are a funded Ebola treatment center, and we're leaders in that area, particularly in the pediatric response during the epidemic in 2014. We also have a congenital Zika program, so we have led in that area as well. So when this came around, we have already built a special isolation unit in our hospital that is specifically designed to if there were large numbers of children, or even not large numbers, but children with something so infectious such as Ebola that need to be contained safely for their care as well as the other patients in the hospital. So we have activated that special isolation unit again for the evaluation and care of our COVID pediatric patients. And we also have implemented rapid testing in our center, which has really been a wonderful thing to have to help get a handle on how much disease is circulating, as well as making it safer for decisions for isolation and precautions for the patient. We've also utilized that rapid testing for monitoring our employee pool because, as you all know, Even though we may not have large numbers of critically ill pediatric patients, we have to prepare for those as they come in the door as if they could be infectious, because children are certainly infected. They may not be coming into the ICU, but they are coming in our doors and can potentially pose a threat to our employees who are taking care then of all of our other special populations at Children's Hospital, including transplant patients and cardiac ICU patients, neuro ICU, oncology patients, etc. So I think I'll end my comments there. We have had children diagnosed at Children's, both that have been very ambulatory and have very minor illness, and we've also had children hospitalized, but no one currently in the hospital, and we're very happy about that. We're continuing to work with our regional network, because I think, and maybe we can talk about this more in the panel, as the adult hospitals take on more and more critically ill adults, which we know will happen, we are working closely as a network to make sure that they have optimized their ability to absorb those adult patients. And we at Children's can help by absorbing any of even the up to 30-year-old young adults for their care. So for instance, what I mean by that is if there's a hospital that has both pediatric and adult patients, it would make sense for them to send the pediatric patients to our facility, which we're specialized to take care of, and that opens up a whole bunch of beds and ICU beds for the actual older individuals that need to be at that particular facility. So these are all areas that are ongoing discussion at both our and other centers, and I'd be happy to take questions later. Thanks.
Thank you very much, Roberta. We'll move on. Jim?
Thanks very much, Yona. I'd like to thank Professors Alexander and Wallace for inviting me here today, and certainly the other members who I have the honor of being on this esteemed panel with, and certainly of all of your interest. The work that I'll be presenting today represents some of the ongoing work that I've been doing with my colleague at National Defense University, Dr. Diane DeUlis, and some of the work that we've been doing with our senior fellow, Joseph Franco. And what I'll present today also represents some of the more recent effort with my colleague, Dan Gerstein at RAND Corporation. Can I bring up my slides, please? Wonderful. So what I'd like to do today is provide for you an overview and a bit of a deep dive into what COVID is demonstrating and what that might yield in terms of lessons learned for multiple order biosecurity risks and threats. And it builds upon what Professor DiBiase had mentioned previously. What that illustrates very strongly is that local scale institutions like Children's, like Hopkins, certainly as we're seeing in the Metro DC area, may face the same type of crisis, problems, difficulties, and essentially failures that we're now seeing throughout New York, particularly New York City. And the issue there is one of the requirements for local, regional, and national support, not only in terms of finances, but also to then mobilize the necessary services, goods, and resource provisions, affordability, and infrastructural maintenance that's going to be necessary to make sure that those vital functions of crisis response to biosecurity risks, threats, are indeed maintained. Next slide, please. Next slide, please. Thank you. The work that I do, of course, as you know, is funded by a number of different organizations. In my current position, both with the DMEC, the Defense Medical Ethics Commission, as well as the U.S. Naval War College and DARPA. Although I'm working with these organizations and institutions, and they've been very supportive of my ongoing work, nothing that I'm about to say here necessarily reflects their views, their opinions, their perspectives. Next, please. This is COVID-19. You know what this looks like. I need not beat this into the ground, but let me reinforce something. There's no evidence to suggest or to verify that COVID-19 represents a weaponized biological agent. Let me say that once again. COVID-19 is not a biological weapon. There's been a lot of miscommunication about that. I've been misquoted in the press as saying there may be instances of that. I've never said that, actually. What I was saying is these may be representative of what you might see for current bio threats and bio risks, given the relative facility of new techniques of gene editing that could allow nation states and perhaps rogue actors to modify existing pathogens like a coronavirus. And I think there's both demonstrations and lessons to be learned. What we see from the COVID-19 crisis, and I really believe in calling this pandemic a crisis, because the literal definition is a time of change. What needs to change? What has changed based upon our previous responses, and what remains to be changed? The process we need to engage is something known as GAME, G-A-M-E. gap analysis, mitigation, and exploitation of those areas of those gaps that can then be filled in to fortify the system on a variety of levels. Clearly, what we're seeing is that COVID presents a clear and present threat to national biosecurity and international biosecurity as well. Biosecurity existing across a number of different domains. Certainly, we're seeing the biomedical threat with regard to impact on individuals' lives lived, as well as mortality and morbidity rates. We're also seeing the psychological impact that goes along with something of this magnitude, and we can't ignore the socioeconomic impact. Most recently, Dan Gerstein and I described this as being on the horns of a biosocioeconomic dilemma. And nobody on this call has lived under a rock. You know what's going on in the media, and you know what's going on politically. On one side, we have the need for the primary best interest of those patients who are currently infected, who are on the route to recovery, and those who are most serious, and yet those who may be infected in the future. As very well illustrated by Dr. DiBiase's graphics in her previous talk, we see that this is an exponential and rather linear trend, and we haven't reached its apex as yet. What need we do to flatten the curve? Well, in flattening that curve, you all know those recommendations coming from a variety of levels, from local to national to international, and certainly this impacts our social dynamics, and those social dynamics are not only psychological in their effect and influence, but certainly are economic. How then do we stem the tide of what's happening on the biomedical level so as to be able to ensure the primacy of those individuals as individuals and persons who may be then rendered vulnerable by patienthood to COVID, to other diseases, and perhaps to other forms of biosecurity risk and threat in the future? And at the same time, seek to restabilize and or stop the hemorrhage that occurs on the socioeconomic level, both nationally as well as internationally, in the short term and more strategically latent effects. And there are political ramifications that go along with this, as you're certainly well aware. Next slide, please. So what are the biorisk and biosecurity considerations and concerns? Well, obviously, when we look at something like this and we consider this in the light of a biological agent, we're seeing that there are a lot of things that could be destroyed. Infrastructures, infrafunctions, the cultural milieu, the social milieu, economic stability, maintenance, worldwide commerce, travel, exchange, and the way perhaps we lead our lives, both as individuals and as communal groups. But if we look at the effect truly of what's happening, it really is more of a mass disruption. And the disruption incurs ripple effects in a variety of scales and levels that then range from literally the biologic all to the base mass effect. If you will, they run from the molecular to the mass, from the cellular to the social. And these effects can be seen as non-kinetic. In other words, we can't talk about this as being viable warfare per se. And although we like to utilize bellicose language in fighting this, and appropriately so, what this also illustrates is that it need not necessarily be a kinetic event, such as an actual warfare event, but rather more non-kinetic influences that can then range disruptive effects in and across a variety of scales that represent the areas of lack of preparedness that may be so endemic. In other words, what we see is that obviously we've been paying attention to certain things, a variety of natural biological threats, chemical threats, and perhaps radiological threats as well as man-made threats. And many of those have been well addressed by prior biological toxins, weapons, and chemical weapons convention, and certainly by viable policies. The activities of DITRA here in the United States, for example, recommends that we've done a fairly good job with many of the existing biothreats, at least those that have been categorized by biological weapons and toxins convention, as well as radiological threats and high explosive threats. But as Mr. Gerstein and I pointed out a couple of years ago, perhaps the biological toxins and weapons and chemical weapons convention require a revisitation, a review, and maybe a revision. And perhaps what COVID-19 and disorders like that are suggesting is that the new vista of biorisks, biohazards, and biothreats requires a new stance of preparedness, not only at the level of international signatory treaties, but domestically. Next slide, please. What are those biosecurity vulnerabilities? Well, certainly many of them lie in the preparedness process. What we need here is an infrastructure and a coordinated set of response functions that engage adequate surveillance, communication of that surveillance with regard to qualification and quantification of burdens, viable risks, and identified threats, and then readiness by virtue of reviewing and revising those areas that are viable, evidentiary, and salient gaps. And there have been a number of things that have happened in the past that would suggest that our area of biosecurity preparedness is less than ideal. I was involved in a 2010 NATO Moldova modeling exercise with my colleague Ashok Vashasta, who was then at the Department of State. And what we were looking at is the viability of a potential neuroagent or a neurocognitive agent. And of course, we were looking at the fact that this may be a natural agent that is in some way modified, either by a nation state or by a rogue actor. But let's put aside the fact that this is something that had a neurological and neurocognitive event. I mean, realistically, that represents my sandbox of expertise. But it could be any event. It could be any biological agent that has the following characteristics: rapid infection, a high level of reproducibility, variability in the morbidity to mortality index, and one to which that has previously had no extant viability or no extant identification. In other words, it's novel on at least one or more of its characteristics. In many ways, this is exactly what we're seeing with COVID. We've had experience with coronaviruses in the past, even those that have been devastating, such as MERS and SARS, but the novelty of this as a naturally occurring biological agent is something that provided for us an illustration of the vulnerabilities in our extant system. However, our Moldova exercise, although was indeed targeted to determine whether or not a rogue nation or a rogue actor might be able to crash the US public health system and all of the socioeconomic environs that are dependent upon it, there have been more formalized exercises on the federal scale that have demonstrated similar things, most notably, and as you've heard most recently in the press, Crimson Contagion exercise. And in the 2019 report to the Senate Intelligence Committee, as both Mr. Gerstein and I have contributed to in the past, Mr. Coates indicated that indeed there is an area of viable vulnerability, and that the United States biothreat biohazard response infrastructure may be somewhat weakened. And as a consequence, we need to recognize the multidimensional threats that exist as a consequence of those new techniques and technologies, as well as the progression of those technologies that are not necessarily weaponizable technologies, but rather the spread of human ecology into animal ecologies that then in some way purloins those environments and changes those environments so as to make spillover effects of zoonotic disorders such as coronaviruses and ever more likely, if not probable, occurrence. If you want to see more information, I have the references that speak to these particular inferences directly on the bottom of this slide, and I can provide those references to anyone who's interested after this conference. Next slide, please. Clearly, one of the things that we were looking at is that emerging technologies can engage disruptive effects. I illustrate for you here a recent paper that my colleagues, Rick Bremseth, Diane Deulis, Lieutenant Colonel Jen Snow, and Joe DeFranco had put in the HTIAC Currents Journal. And what we illustrated is that, in fact, the level of misinformation, miscalculation, and ultimately misresponse would decrease any particular stance of preparedness and create a leftward shift in the acceleration curve and a rightward shift in the durability of how such an effect, particularly on the biological security and biothreat scale, would then impact the United States across a range of dimensions, inclusive of the biomedical all the way out to the sociopolitical. Next slide, please. Well, if that's describing the relative dark, if you will, how then should we light a candle? I think if we look to places like New York, or if we look to countries such as Italy, we see that there are real problems with regard to the way the response has been handled, vis-a-vis surveillance, then translating into quantification, then translating into countering the threat, and then moving into a preventive stance. However, if we look at other countries, for example, South Korea, if we look at Singapore, if we look at China, if we look at Germany, we see a slightly different profile. Now, certainly I'm not suggesting that we move from an open society to a more closed society as we see in our trans-Pacific competitor. But there is something to be said about mobilizing a response when in fact there is continuity, contiguity, and conjoinment of response and awareness between all the necessary levels of government that are required to maintain biothreat response capability. What we're looking to do is to re-engage a four-thrust strategy. Re-engage, and the reason I say that is this strategy had been in place previously. It had been in place during the Second World War, it had been in place during the Cold War, and the mobilization of whole of government to be able to detect this threat early and then make responses rapidly and in a way that are flexible maintains the fixity of this purpose. We've grown somewhat lax in this response. And the responses that we see in a place like Children's Hospital, where indeed they're changing resources and becoming flexible in the way they're able to treat not only those patients that are their standard patient care load, but also the crisis patients that are coming in given this new pandemic, I think represents the type of flexibility that is required. But to reiterate, even the wonderfully notable responses of a place like Children's Hospital can only be potentiated, maintained, and sustained in a preparedness stance if there are local, regional, and national resources that are dedicated to it both structurally and functionally. So what we call for is a 4-thrust strategy. The first, increasing the awareness, which also involves deep surveillance. We don't have the time in this particular conference, this panel, to discuss what deep surveillance means, and certain aspects of deep surveillance need also be classified. But certainly, for those of my colleagues who maintain that clearance, or for those who sort of want non-guilty knowledge and talk about it in a more open forum, please feel free to get in touch with me and we can talk about what that means. Certainly my research group, Dan Gerstein, Diane Diulis, and my colleagues are not the only ones who have addressed this, and ongoing discussions within DITRA, OSD, ODNI, have addressed and engaged discourse in the possibilities of what deep surveillance means on the 21st century world stage. Well, that awareness, surveillance, and essentially salience of what those risks and threats are then must translate into not only qualification of what they are, naming them, if you will, finger pointing at them, if you will, and recognizing here's something that's on the proximate horizon that represents a risk that can translate into a threat. But what is the quantification of that threat? Just as we've seen here today in Dr. DiBiase's presentation, quantifying by virtue of modeling, gaming, and forecasting what the impact influence manifestations in both the immediate as well as short term to then translate into the more longitudinal and long-term effects would be, and that then quantifies the relative burden, benefit, and risk strategies by which devoting resources to addressing these risks and threats should then be maximized. The third thrust is to actually counter the threat, and very often countering the threat before it poses the type of linear risk and or influence that are so well illustrated by our previous speaker slides. And ultimately the goal here is not just mitigation, but prophylaxis, preventing the threats, delaying future adversarial effectiveness. And this need not necessarily be a geopolitical or interpersonal adversary. It can be a biological adversary. Certainly something like COVID-19 represents such an adversarial opponent. And what we see is the bellicose language that is now being leveraged is certainly appropriate in this case. But what that really tells us is that bellicosity of response needs to be preempted. It needs to have some form of propedusis, if you will, something introductory that's necessary to be able to get the right work to identify that target before that target has occurred as a bang. In other words, we have to work left of bang or left of boom in a more effective way. Those resources may be in place, but the question is, are they in place in a coordinated way so as to mount a preparedness response? And are they also in place in such a way that would then allow their sustenance for what would be a relatively long haul? If in fact the threat then is realized, how can we then mitigate that threat, reduce that threat, and then rebound from that threat? Our hypothesis, working with another colleague of mine, former Captain Rick Bremseth, the United States Navy SEAL, says that the whole of government is certainly important. And I think that in recent days, we've seen a mobilization of whole of government resources, or at least a call for that. One need only listen to Governor Cuomo's call that the government needs to respond nationally to a very localized state crisis. And of course, what we might see is that the infectious spread of that indeed red hot infectious state of New York might then induce changes throughout the eastern seaboard. What do we have to do to be able to mobilize to mitigate, if not prevent, such a threat from them becoming an ever more viable and ever more destructive vulnerability? We've called for a whole of nation approach that's going to be necessary to identify, characterize, counter, and perhaps exploit and prevent those biosecurity risks and threats to the United States public health and socioeconomic stability. Lessons learned from COVID is that in many ways, we got caught with our knickers down around our knees. And the question is not so much now, how do we pull them up, but how do we belt them up and girdle them securely so that in fact, what we learned from this is never again. Next slide, please. The 4-thrust strategy involves whole of nation resources. And arguably, and I think defensively in my argument, if we look to those countries that have mounted a viable response that has flattened the curve to COVID, what you're seeing is the relatively seamless articulation and engagement of the 3 phases of the triple helix of government, the research entity, and the commercial enterprise. Government on a national level as well as a local and city level. The research enterprise, both with regard to academia, as well as the private research enterprise, as well as the commercial enterprise necessary to mobilize all of those resources to stabilize an economy in such a way that then mounts what might be a war response against this adversary, natural or otherwise. What would that look like if we were going to employ such a 4-thrust approach with a whole of nation engagement in the United States? Well, take a look at the slide that's before you. What we see is that as thrust 1, folds into thrust 2. We engage academic institutions, research centers, and the intelligence community across all of its multiple domains. Certainly all of the 3-letter agencies and perhaps 4-letter agency, the Office of Director of National Intelligence, can be participatory in this and working to identify those viable risks that could become threats through deep surveillance. As we move from thrust 2, quantification into counter, we then engage law enforcement, Homeland Security, H&HS, national laboratories, and industries. And we're seeing that now in the attempt to, for example, mobilize Gilead Sciences to produce more of the viable antiviral that may in fact be useful. We're seeing calls for law enforcement, national laboratories, as well as Department of Homeland Security to create quantifications as well as qualifications of those patients who may be infected, those patients who may be at risk, and those patients who may be recovering. Again, I'm alluding here to some of the recent work of Dan Gerstein and I, who've called for such a quantification and characterization of these patients, not only in terms of maintaining the public health, both at large and of individual patients who may be at risk or vulnerabilized, but also trying to balance that on the other horn of the dilemma, which is socioeconomic instability and ultimately the disaster that may affect for long-term economic closures. How do we essentially get a workforce back in such a way that those essential services are provided, and yet we're decreasing the risk to not only the current population, but future populations, and then stabilize something like COVID having a seasonal effect that is equally devastating in each one of its seasons of representation? And this is really where thrust 3 goes into thrust 4. What do we need to do to prevent, delay some type of future adversarial effectiveness, whether it's a natural agent or a man-made one? And here we're looking at conjoining the Department of Defense, Homeland Security, State Department, and intelligence communities, not singularly in isolation, but as a coordinated effort with all of those other agencies that are participatory in the whole of the nation. And in each and all of those, these are requiring public information, public response, and public trust. And public trust can be mobilized when the threat is adequately quantified and identified, and in fact, the resources are demonstrated to be available to then show the public that indeed the fiduciary has not been fractured. So again, I think that this is something we can learn from. My hope is that we're able to mobilize the resources in such a way, as you've seen from our previous speaker, within Children's Hospital. The Children's Hospital model working on a larger scale within the metropolitan DC area, I think would be wonderful. I think to utilize that model on a regional and national scale would be ideal. Obviously, this is going to require different levels of support than have currently been provided. In other words, a preparedness index, if you will, the preparedness quotient needs to be remedied and recuperated so that in fact our response can be reliable. Next slide, please. In summary, what we're saying here is that there are biosecurity risks and threats, and they're increasing. Certainly by virtue of natural intrusion to a variety of ecologies that has then disrupted the delicate balance between those particular viruses and other forms of microbes that heretofore have been specific to other species, but now may have spillover zoonotic effects, and certainly the capability of some of the things such as gene editing and other forms of advanced biotechnology that might render the viability of modifying existing agents and making new agents anew that can then be used to evoke the exact same types of effects we're seeing here with COVID. Clearly, to do this, one of the things we've advocated is some type of a program management office or a program of record now that funds research and technologies, innovations and countermeasures and solutions, and provides ongoing support for the types of things that my colleague Dr. DiBiase illustrated that appear to be so effective in combating this crisis at this time and perhaps in the future. Need the capabilities to address and defeat various biosecurity threats, remaining ahead of competitors' abilities to exploit US weaknesses. And here what we're really talking about is not necessarily taking a bellicose or competitive stand, but rather a cooperative stance. Remaining ahead of those abilities very often involves cooperation so that indeed we can work together so as to exploit in a positive way the various hegemonies that our international competitors may be able to evidence and work with them in such a way that is cooperative, recognizing that the threat here is not just to a particular people, not just to a particular nation, but may be global in its impact that would change the entirety of the balance of power, in which case the sinking tide will lower all ships. And ultimately, if we're going to mobilize in these ways, and we recognize that many of our international cooperators, allies, and even competitors are engaging a whole of nation, relatively seamless triple helix approach, the only way to be able to engage with them in a cooperative way that is functional and in that way be collegial and yet competitive in terms of capability is to equally develop, design, and implement a whole-of-nation approach that at very, very least can be rapidly and capably mobilized in those times and situations that demand it. Next slide, please. For those of you who are interested in some of our ongoing work in this area, we've been playing in the sandbox for over a decade. And unfortunately, the current COVID crisis illustrates all too well that there remain gaps in the system. Our hope is that what this actually provides us with is insight for gap identification, analysis, and successful and expedient compensation. Next slide, please. I only have a few minutes of your time here today, and hopefully we'll have time to answer questions, but with my other esteemed colleagues on this panel, there's going to be a lot of information here. And some of the things that I may have spoken to you about might need to percolate a bit. And so if you need to get in touch with me, please feel free. Contact me at any time. This is my email, james.giordano@georgetown.edu. It'd be my pleasure and honor to work with you. Thank you very, very much for your time, your patience, your understanding. Please stay healthy. Thank you.
Very much, Roberto and Jim, for providing the context for our discussion today, which reminds, I'm sure, many of us that we have to act locally and think globally. And obviously, the two presentations triggered a lot of issues and questions, including the definitional one, which is very interesting because of the latest Justice Department guidance how to deal with this exposure, particularly related to the definition of a bioagent and linked to terrorism and so on. So we'll have a chance to discuss this later on. But this brings me, of course, to our next panelist, Ambassador Charlie Ray, who spent many, many years as a diplomat, and you can probably provide us with some insights on the role of diplomacy to deal with that problem. Charlie, please.
Thank you, Yona. You know, the 2014-2016 Ebola outbreak that ravaged countries in West Africa infected more than 28,600 people and killed about 11,300. It's believed to have actually started in December 2013 in a small village in Guinea when an 18-year-old boy was infected by bats. It soon spread to Conakry, the capital, and in March 2014, the Guinean Health Ministry issued an alert for an unidentified illness. Pasteur Institute in France confirmed that it was Ebola, and on March 23rd, after 49 confirmed cases and 27 deaths, World Health Organization officially declared an outbreak. By July, Ebola had spread to Sierra Leone and Liberia, and from there to Italy, Mali, Nigeria, Senegal, Spain, the UK, and the US. In July, the US Centers for Disease Control and the Department of Defense deployed personnel to West Africa to assist in training healthcare workers and expanding lab capacity. Now here we are less than 4 years later. The world is again facing yet another deadly infectious disease, the novel coronavirus or COVID-19. COVID-19, believed to have originated in Wuhan, China in December of last year, has already had a devastating global impact that dwarfs the Ebola outbreak. Researchers say it started with an infected bat's transmission to an animal that ended up in Wuhan's meat market where it infected humans. 3 months later, it's been officially labeled a pandemic, and it's infecting people on every continent except possibly Antarctica. Now, unlike the Ebola crisis, where the health, economic, political, and social impacts were felt most keenly in the countries of West Africa, COVID-19 has had a global impact. It's affected world economies, and it has the potential to create political instability and to exacerbate existing political instability on a pretty wide scale. Global supply chains have been disrupted, affecting the price and availability of not just consumer goods, but emergency medical supplies such as test kits, masks, and respirators. Global stock markets have been on a roller coaster, mostly going down, with US markets suffering biggest losses in history. With travel bans, lockdowns, and border closing, local economies around the world in many cases have come to a virtual standstill. I mentioned political instability. That's a real risk that we have to recognize in a situation like this, especially in countries like Iran and North Korea, which also puts neighboring countries at risk. And while from a public health standpoint, quarantine of infected or potentially infected persons, cordoning off certain hotspots, and limiting or banning mass gatherings is not only prudent, but necessary. But adopting a go-it-alone attitude or shutting out the rest of the world completely, I don't feel is either prudent or wise. As in the Ebola outbreak, although on a much larger scale, what is needed is increased global cooperation on the scientific, technical, and medical level. We need economic cooperation, and probably more importantly for the future, we need political cooperation. Our global economy is far too intertwined to completely unravel, but we do have to make some adjustments if it's to recover or to survive in a fashion that ensures adequate living standards for the people of the world. And this won't happen in isolation. Just as an example, 80 to 90% of US antibiotics either come from China or rely on components made in China. In India, the largest supplier of generic drugs and major vaccines, they've cut exports of 26 drugs because India relies on China for 70% of its drug components. An attitude of isolation not only is unworkable, but it puts increased strain on the already strained alliances at the very time we need them to deal with the potential instability in hotspots like the Middle East and the Korean Peninsula. Among the many things we need to do, though, in order to get through this current crisis, recover from its effects, and ensure that we're prepared for the next one, and sadly, I do feel that there will be others, is to revitalize our moribund diplomatic capability. An often overlooked tool of statecraft, diplomacy is essential to building and maintaining the web of relationships that are critical to mounting global campaigns against global threats. History has shown this to be true, and we can't afford to ignore history, frankly, because we cannot afford to repeat it again. Thank you.
Thank you very much, Charlie, for your insights, particularly at the time of the so-called unreliable, maybe global leadership. And I think we have to look at the role of diplomacy perhaps more critically than ever before. Now we're going to move on to our last panelist, Ford Rowan. As I mentioned before, he was engaged in conflict resolution for many years and the role of the media, fake news, if you will, etc. And I think this is another very important interdisciplinary perspective that we have to consider seriously. Ford?
Thank you very much, Yona. I appreciate it, and I'm glad to be here, and I'm honored to be here with all these other distinguished folks. I advise, I do a number of things. I'm a retired lawyer. I advise companies, and I advise the University of Maryland Global Campus and the president of that institution, Javier Miyares. I do conflict resolution work. I've done work in Istanbul, in Turkey, and also in Northern Ireland, in Belfast, and in other places, including Jerusalem, almost without success in most of those places. I want to talk about, the name of my talk is Surfing the Next Wave of the Pandemic. And I'll tell you why I picked the surfing metaphor. I want to talk about how employees will perform when they're called back to work sooner or later after being stuck at home. I'm going to talk about the role of the media, but I'm also going to talk about how we re-engage the workforce while there are still new cases of COVID-19 being diagnosed, and how we may feel like we're, and sometimes this will feel like we're swimming in a riptide if we're trying to bring these workers back into working with our companies. Now, I have some suggestions on the care of those who work at businesses, large and small, at nonprofits, at government agencies, and not just in the US, but everywhere. I agree with Charles Ray when he just said our economies are interrelated and we're all facing global threats. They're very different kinds of, quite a different variety of threats. The first thing that we should understand about this pandemic is that there will be a next wave and new cases. It may come as part of the first wave, especially if we get the go back to work order around Easter in the United States. As of yesterday, we were told that that is President Trump's aspiration. We're told by the news reporters that the medical doctors and scientists are warning that this is too soon. Number one, is this real news? You always have to ask yourself that question. Now, I'm a former news reporter. I covered the Nixon White House. I covered the Watergate trials. I was a Pentagon correspondent at NBC News, saw combat in Lebanon. And then later I had a TV program, International Edition on PBS. I say all this because all of that happened in the dark ages before computerized social media, tweets, and round-the-clock news on cable. The news is bad, it's still bad, and it always will be, because bad things are more interesting than the good news, especially if there's conflict. So think of this kind of a conflict, which is not really hypothetical, it's emerging. What happens when hospitals run out of ventilators? Who will decide who gets to live and who gets left without help and will die? When such triage comes to your nearest hospital, how will you feel about the ethics of life and death choices? I'm on the advisory board of the Berman Bioethics Institute at Johns Hopkins, and they've studied ways to decide. And they're really asking, how would people feel? How would you feel if it was your child that was not given life-saving treatment? Or if your elderly relative is passed over in preference to a teenager, a healthy teenager? And I think that's not necessarily going to be, and unfortunately, it's not going to just be a hypothetical question. I think we're facing that if we don't have enough hospital supplies in time. And a lot of the efforts to reduce the curve, to round it out, is to try to make sure that our hospitals can handle these patients. Now, leaving aside the outliers, the conspiracy theories, the junk science, and the nonsense about death panels, the news provides a pretty good account of the problems that we face. Most news is bad, and most bad news is true, unfortunately. But is it fair? That's a different question. Is it fair? When I started in the news business in 1965, my first boss told me, and I quote exactly, because I remember this, quote exactly, "I don't give a damn about your opinions, and I damn well don't ever want to figure out what your opinions are while I'm watching you on television." And I've never forgotten that. Now, I know I'm getting old because I think, well, it's all gone to hell since I left. But the fact is, it's not just the facts, ma'am. I wrote a book in 1984 called Broadcast Fairness, about the fairness doctrine and equal time rule, and a lot has changed since then. Let me be clear. I believe there are a lot of serious journalists and major publications that seek to be fair and present all the facts. In print and online, opinions are usually clearly identified as opinions. We're saturated with opinions across the entire spectrum. And here's the issue. The news media amplify the risks of whatever's happening because they're conflict-oriented, they're bad news-oriented, and they're always looking for interesting things. And unfortunately, we all are more interested in what went wrong than what we're doing to try to fix it. Now, one of the good things about social isolation is that the educational system is finally forced to realize that computer learning is not only good, it may become essential. Young people have no problem learning online. The University of Maryland Global Campus has some of the most interesting students, international, all online, thousands of young people, and many of them are working adults. We've been doing distance education for decades. Professors engage meaningfully with every student in the class every week, regardless of where they live. Online is the future. The virus hasn't figured out how to teleport. So let's talk about what might happen in the old-fashioned workplaces, many of which have not quite gotten to the place where everything can be done out of immediate proximity. The coronavirus has not peaked. Reported infections are doubling every 2 days. So the coronavirus has not peaked. We're still on the wrong side of the curve, with parts of the country just starting on the upward roller coaster. Clearly, we also need to go back to work. Our economy is sick. Some say it's in shock. Just today, the federal US government announced that a record 3 million persons have applied for unemployment compensation. That's a gigantic increase. Let me tell a story. I'm from New Orleans. A main industry in New Orleans is tourism. I watched a video of the Mardi Gras celebration 4 weeks ago. There were revelers enjoying Carnival, having a great time on Bourbon Street, crammed together, cheek and jowl. Guess what came next? The hangover, the corona hangover. We've had an incredible jump in cases of people testing positive, being admitted to hospitals, dying from COVID-19 in New Orleans. It became a hot spot because several weeks ago, everybody decided to en masse go out and celebrate. So much for efforts to keep people 6 feet apart, to distance oneself from others who may be asymptomatic carriers, to isolate and prevent the spread of the disease. And this is not just about the elderly. 38% of Americans hospitalized for COVID-19 are between the ages of 20 and 54. Now, our President Trump, has an aspiration. We should go back to work. The economy is struggling, but it's not on life support, not yet. But no matter how soon we go back to work, there will still be a virus infecting new victims for months. The first wave isn't over yet. How would you feel about giving up shelter in place in order to immediately start toiling with other people in a same space? Right, you've been told this, you got to be isolated, and now all of a sudden you're told, go back to work with all these other people. How will your organization explain to you and your fellow employees what it is going to do to protect us in the new environment? How will you deal with such concerns? Concerns you probably share. Concerns about infection that are real and not fake. Even if you develop ways to help employees to distance themselves at work, try to stay 6 feet apart or whatever, nothing's perfect. I like the comparison of surfing because the waves will keep coming. The waves will keep coming. And even when the first wave of the coronavirus ends, will there be a second wave like there was 100 years ago in the Spanish flu epidemic, when the second year was more deadly than the first year? What about flu epidemics in the future? What about bioterror attacks like the anthrax attack two decades ago? What about nuclear accidents? I covered 3 Mile Island, and I saw how freaked out residents were about an invisible threat. Isn't dealing with these psychological threats something that needs to be done continuously and updated and added to organizations' capabilities? Aren't psychological issues related to the coping with health and safety threats? Now, my colleague at UMGC, Professor Donald Donahue in the business school, reminds us that extended stress degrades the body's immune system. Champion athletes succeed because they're mentally focused, physically prepared, and share a singular goal. Employees are no different. Well, what are some of the psychological challenges? First, distress about new advice that conflicts with the prior advice. Shelter in place, the prior advice. altered perceptions about risks, fear and suspicion about management's priorities, unexplained physical symptoms, inability to sleep, angry arguments about risk with spouses at home, self-medication with alcohol or drugs, triggers for psychiatric illness, worries about family and future. Misleading information, false assurances, and failure to address these frightening feelings will result in reduced productivity, increased absenteeism, maladaptive behaviors, and conflict in the workplace. Now, how can we get ahead of the wave, on top, and improve resilience? One of the biggest challenges is improving resilience in organizations, in our country and abroad, and I think all across the world. Well, here are several steps that we can take, and take as individuals, take as leaders, encourage others to do. First, show you care. Now, that's pretty simple. A lot of these are kind of simple. You've heard them before, but sometimes our organizations don't practice what they preach. Show you care, because workers will perform extraordinarily if they believe you have their back. Listen carefully to their concerns. You know, most people, when they talk about communication, they talk about what I say. What we really ought to be doing is, what do they hear? And more importantly, what do we learn? Demonstrate some empathy. Address concerns with consistent, credible messages. Improve environmental hygiene, for example, with frequent cleaning of common surfaces. Encourage those who feel ill to stay home. This is important because we're fighting presentism, the bad idea that you must show up to work even if you don't feel good. There are a lot of other good ideas to build resiliency. Several years ago, I co-authored a study that was published at the National Defense University Center for Technology and National Security Policy. The name of it was called Weathering the Storm, Leading Your Organization Through a Pandemic. I'm told there are over 10,000 hits downloaded this. It's for free. It's on the website of NDU, and it's on my website as well. The link to my website is fordrowan.com, and the link to the NDU's website with Weathering the Storm is right there. The address is on the screen right now, and I appreciate that. Let me say in conclusion, I share the President's aspiration for a good Easter, but I fear that our workplaces are not ready for re-engaging with employees and confronting the coronavirus. And let me say in conclusion, not all aspirations are healthy. For example, pulmonary aspiration can be debilitating and deadly. In conclusion, final word, in conclusion, take care of your health, take care of your family, take care of your colleagues at work, love your neighbors. Thank you.
Thank you very much, Ford, for your insights. As you mentioned, the book, The Weathering the Storm, that provides guidance in this pandemic crisis and others. I'm sure we'll come back to you later on. Now, after completing the first phase of our discussion with the panelists, I would like to move on quickly to our colleagues who will join us hopefully either by phone or through the video process. And I'm going to invite first Mark Norman, if he's there, State Department Bureau of Counterterrorism.
I am.
Are you on?
I'm on, yes. Mm-hmm.
Okay, would you kindly make your presentation or comment, whatever you would like to recommend?
Yes, certainly. First of all, thank you all very much for having me. And probably most importantly, I hope everyone is taking care of themselves and trying to get through this very difficult situation in the best way possible. I was asked to talk a little bit about the impact of the current situation on our counterterrorism activities and I guess on terrorism writ large. And I guess I would begin by saying what's probably a fairly typical State Department response, which is that it's a little too early to tell. There seem to be a number of different things that are happening already, and probably a number of other things that seem likely to happen. But I would caveat everything I'm about to say by making the obvious point that we really don't know how this is going to play out and what sorts of fallout there will be from the current situation. So let me begin with a couple things. I think the first again, an obvious point is that the world is now completely focused on dealing with combating the coronavirus. So this obviously has implications for the ability of governments around the world, including our own, to focus on other threats, and in particular, in this case, terrorism. It also has resource implications, obviously. As you've seen in the United States and in other countries, security services, and in particular the military in a lot of places, are already being used to try and enforce curfews, to try and provide security, to try and do all sorts of things related to the virus that obviously may diminish their ability to respond or to deal with terrorism issues. So that's obviously the current bad news. The relatively good news, I suppose, although I'm a little reluctant to put it exactly that way, is that terrorists are also affected by the virus situation. And we've already seen, I think many of you will have seen statements from ISIS, among others, warning some of their adherents not to travel to Europe. This was a few weeks ago. And clearly it will have disrupted the increased security that countries are implementing all across their borders to prevent travel by infected persons will have an impact on the ability of terrorists and others to travel. Same thing with the generalized breakdown of cargo travel and things like that. In other words, it's having an effect on the terrorists' ability to do the things that they want to do in a number of places. Longer term, I guess it really depends on the extent to which the virus affects the population at large. If there are major societal breakdowns, it may be possible for terrorists to exploit that sort of thing. If there are situations where security services become dysfunctional because of widespread outbreaks of the virus amongst their personnel, that may enable terrorists to be more effective at doing what they're trying to do. Conversely, again, the obvious point, but still, terrorists are just as susceptible to getting the virus as anyone else, and we're already seeing places where they operate that seem to be at risk of severe outbreaks. I think Afghanistan is probably a pretty good example. So let me turn very quickly, because I certainly don't want to take up too much time with this because so much of it is speculative, to talk about what we're focusing on and how perhaps the coronavirus crisis may affect that. I would begin by saying, again, an obvious point, which is that we are looking right now at what you could call, for lack of a better term, in terrorism terms, as the post-physical caliphate world. So we're looking at a number of things in that regard. The first being the issue of ISIS affiliates around the world, and how to deal with them, how to sever communications amongst these various groups and with their central command, such as it is. With respect to that, the virus obviously has, again, as was mentioned, has an impact on their ability to travel, probably less so on their ability to communicate, and it also has an impact on their ability to share resources. So from that point of view, I think preliminarily it may make our lives a little bit easier in that very specific term, at least over the short period of time. Another thing we're focusing on, obviously, in the post-physical caliphate world is terrorist travel. Again, that's complicated by the restrictions being put in place by governments around the world. Foreign terrorist fighters, trying to repatriate them is something that we've been working on. This has been a difficult task to begin with. It's not likely to be helped by the current restrictions on movements of people around the world. So that's the ISIS thing that we're looking at. Second thing that we're looking at is Al-Qaeda. I think most of the same overall points apply to Al-Qaeda as they do to ISIS. Difficulty in travel, difficulty in moving things increased. I would add that because Al-Qaeda is, to a certain extent, operating or trying to take advantage of some of the situation in Afghanistan, where again it looks like that's going to be a real focus for the virus, it may have an impact on their ability to carry out some of the things that they want to do there. third big thing that we're looking at is Iran and Iranian-sponsored terrorism and groups around the world. I think we're all aware of where the virus situation is in Iran. It seems to be one of the worst places in the world in terms of fatalities, in terms of the government's lack of ability to deal with it, and in terms of a number of other things. Clearly, that's going to have an impact on Iran's ability as the world's leading state sponsor of terrorism to devote resources to sponsoring terrorism as much as they have been doing in the past. So from that point of view, again, short term, it may make it more difficult for them to do some of the things they want to do. We're seeing anecdotal stories as well. That, for example, in Lebanon, where there have been some outbreaks of the virus, that some people are blaming Hezbollah for that, in terms of their leadership and others having traveled back and forth to Iran. That obviously would be a public relations success if it can discredit Hezbollah within the Lebanese system and political environment. I think, obviously there'll be countering narratives and all sorts of things like that, but at least temporarily, I think both Iran and possibly its most important proxy are going to be focused on dealing with the virus, at least for the short term. And so that will have an effect. The final thing that we're looking at these days in the post-fiscal caliphate world is what we're calling racially or ethnically motivated terrorism, REMT. I'm not sure. Again, I think most of the impact of the virus is the same as with everybody else. We have seen some indications in discussions among some of the adherents to these various racially and ethically motivated terrorist philosophies, as we have with other terrorist groups, of trying to figure out ways to weaponize the virus in some way. I'm not sure what that means. I'm not sure they have the technical capabilities to do that sort of thing, unless they're talking about sending infected people out and coughing on other people. I think this is one of these things that may be more aspirational or speculative than anything else, but it's something that we're keeping an eye on, as we are with all of the other groups. So that very quickly is I think where we are in terms of countering terrorism and the virus. And again, I would end just by saying, as I began, that all of this is highly speculative, all of this is highly preliminary, and it really is going to depend very much on the course of the virus and its impact on populations, governments, and resources as things unfold over the coming months. So with that, I can just stop.
Thank you very much, Mark, for your contribution and also support of our academic work and your colleagues at the Bureau. Thank you very much. We're going to move on to our next commentator, Dr. Daniel Gerstein, former senior U.S. government civilian official, as you probably know, also acting under Secretary for the Department of Homeland Security, Science, Technology, and is currently at the RAND Corporation. And I want to thank him also for his support of our academic work, and he spoke at our event at the ILI on the role of technology. Dan?
Thanks, Yona, and thanks for inviting me to participate. Very interesting to hear my colleagues talk about their perspectives. What I'd like to do today is offer very, very briefly my perspectives and focus on the societal impacts. So I have 6 very quick points. The first is we are in the early stages of this global pandemic. Unfortunately, we are not in the middle, as some have tried to paint such a picture. That means that there is a long way to go as we are looking at societal disruptions as well as casualties, both mortality and morbidity. So the news is not good here. We've just passed a landmark in going over 500,000 confirmed infections, and we have an exponential increase ongoing. My second point, and I'd like to just share with you some key analytical data points that talk about just how bad this could be. The first is the United Kingdom's Imperial College analysis that said that up to 2 million US citizens could die if no interventions were put in place. Now, thank goodness we have started interventions, but we were late in doing so. We will see how that will be affected. Hopefully, their analysis is overstated. But the CDC, Centers for Disease Control and Prevention, also looked at 4 scenarios, and they looked at the scenarios ranging from 200,000 to 1.7 million US deaths without intervention. Again, interventions are ongoing, but still we see a lot of activity with respect to increasing infections. My third point is, unfortunately, I have to say that the lack of transparency has been hindering global response efforts. And here I would focus on 2 nations. I would focus first on China. We were slow internationally in understanding how this was evolving. It looks like it started as early as late November. And they were very slow in getting us information that could have been very beneficial internationally. The second nation, unfortunately, is the United States. We have not been transparent in terms of what the effects might be. We have not done a very good job of communicating with our people. And I think that is going to present itself with very concerning outcomes. In fact, another set of milestones, China has 81,000 confirmed cases. Italy has 80,000 confirmed cases. And as of right now, the US has 79,000 confirmed cases. So when you look at those numbers, it says the US is on a glide path to become the nation with the most confirmed infections. My fourth point is looking at preparedness and response. And here I would have to say that I think we have regressed. I think that our institutions have fallen down in terms of some of the preparations that have been ongoing. In my former department, Department of Homeland Security, I think there are some very significant issues. We worried about this with the number of secretaries that were there, and it's playing out. But there have been other issues, such as the personal protective equipment, the masks, the respirators, and gowns not being replaced within the strategic national stockpile. We didn't have very good diagnostics. The PCR machines for looking at who's infected and serological testing to know who has developed antibodies and previously been infected. We don't have a vaccine. We know it's going to be 12 to 18 months. And I know people are working hard on that. Same with therapeutics. The fifth point is, I think this is an inflection point in our history, in our global history. And I think we're going to look at history very differently. We're going to look at it as pre and post COVID-19. The changes that are being ushered in now are not going to be easily reversed. First, societal. I think the growing isolation, the societal breakdowns, increased incidences of depression. We are going to have to work very hard to ensure these do not turn into very severe outcomes as well. The economy. Jim Giordano talked about the work that he and I are doing. We have a paper coming out on CNN, hopefully in the next day or so, talking about people getting back to work. But we're going to have to think about this. We call it on the horns of a dilemma, because you definitely have to get the economy going, but you cannot have loss of life just to get the economy going. So how do we balance those two? Jim and I have developed a strategy looking at just one small piece of that, and that has to do with diagnostics and getting those people who have been infected and have developed antibodies back into the workplace as soon as possible. I also think that technology and innovation, we've seen some good outcomes here, and we've seen some not so good outcomes. But, for example, we're seeing the use of 3D printing of parts for oxygenators. We're now seeing global supply chains that are literally going to end at our front doorstep. We've seen innovations such as repurposing sleep apnea machines, CPAP machines, to be used for those people who do not require the invasive oxygenation. We're also seeing increased use of telemedicine, teleeducation, and telework. And that's a trend which I suspect will continue long into the future. We are looking at artificial intelligence applications for interviewing people who might be infected to avoid having them present in hospitals where they would infect others. But I would also submit that new technology is going to be required. And here it's not so advanced as it is. We just need to make sure it's more available. We can't expect people to do telemedicine and teleeducation and telework if we don't have 100% across the United States assured broadband and personal computing capacities. So we may need to think differently about these key components of our new life. And the final point is at some juncture, I suspect we are going to have, just like we did with 9/11, a national commission on the coronavirus preparedness and response. I would emphatically say this coronavirus is not a black swan event. It is the whitest of white swan events. We have been talking about this in earnest since 2005 as a minimum with the H5N1 preparedness. And somehow we have lost our way and we have regressed. And with that, I will stop. Thank you.
Thank you. Thank you very much, Dan, for your overview and warnings and so on. Looking forward to your work, future work. I'm going to ask now Dr. Richard Reff, if you are there, to join us.
I'm here.
Wonderful. Dr. Reff is orthopedic surgeon and sports medicine specialist, and he played some key roles related to the Olympics, U.S. Olympic Committee, the Maccabiah Games, etc., etc. And I thought this is quite timely, maybe to mention something about the Olympics and the sports concerns.
Well, I have, first of all, I guess you would call one of the frontliners, because I'm in active practice of orthopedic surgery. And I'm in private practice in the Washington metropolitan area. And we're out there. We're out there trying to do our best. We're facing many different challenges. First of all, the whole technology issue with telemedicine for an orthopedic surgeon is a very difficult situation. As the previous speaker mentioned, the lack of consistent broadband technology around the local area and around the country certainly puts a lot of constraints on the ability to perform adequate telemedicine. The other issue is that I'm a hands-on doctor. I treat people who have musculoskeletal problems, who have fractures that you really can't take care of remotely. However, we're beginning to evolve by beginning to try to train our patients as to how they can be the assisting virtual reality hands from a distance when the situation arises. Dr. Giordano certainly put his finger on a big problem that we face out in the field, and that is the lack of public trust to what the information that is being disseminated by either the political so-called experts or other experts. From the standpoint of going not from the global perspective, but going to the basic unit, the basic family unit, because this is what's really being affected today more than anything else in this country. there's a quote from Lee Iacocca that said, "In times of great stress or adversity, it's always best to keep busy, to plow your anger and your energy into something positive." So we're also faced with this major challenge today as we have in young people. Young people have been involved with organized activities, sports activities where the parents take them here, the parents take them there, and virtually the philosophy of free play, which was what I grew up with, has never been utilized in this generation. So now they're beginning to have to learn on the fly. And as other very erudite people have said, necessity is the motherhood of invention. And since stress and the psychological component of what we're going through, I think is not something to be underestimated. That again, with what Mr. Rowan just said about that stress is also decreasing our ability to deal with illness, but also because we're getting more stressed because of the conflict of information and services. It demands of those people who are in a position of authority to start to separate fact from fiction, and that's one of the big problems that we're seeing out in the field. And with that, I'll mute and listen.
Thank you very much for your insights. Dr. F., I know you will join us also in our upcoming event in April 14th. So we'll talk more about the Olympics, I guess. At any rate, I want to move on very quickly. Is Dr. Tevi Troy there? Well, Tevi?
Yes, I'm here and I'm now visible.
Oh, wonderful. As many of you may know, Tevi is the former Deputy Secretary of the Department of Health and Human Services, and recently published this book, To Wake Up the President. Maybe you can deal with that as well. And we look forward to your comment.
Great, thank you. Do you want me to speak for about 5 minutes or something, or what are you looking for?
Well, you can speak for as long as you want, but try to finish in 3 minutes.
Okay, fair enough. Well, yes, thank you, Giordano, for having me on. I am indeed former Deputy Secretary of IUCTS and author of the book, Shall We Wake the President? It is a book that looks at how presidents have dealt with disasters dating back to the earliest beginnings of our republic. And what I note in the book is that there was little expectation in the 19th century that presidents would get involved in disasters. And it is a phenomenon of really the 20th century, as we have instantaneous communication and rapid travel and a larger and growing federal government that gets people aware of what's going on the disaster front. And then we now have a period where there's an expectation, if there's a disaster, the president will get involved. So I tell a story in 1889, the Johnstown flood, largest loss of life on American soil in peacetime in history at the time. And the people of Johnstown reached out to President Harrison and asked for his assistance by telegraph. And he responded by telegraph, "You should really go to the governor for this assistance, not really my job." And they responded, "Thank you." Now, I can't imagine a locality asking a president for help these days and the president saying, "Go to your governor," and getting a thank you. But that's just how much things have changed over the last century plus or so. Now we're in a situation where the president and the federal government are expected to deal with these kinds of pandemic outbreaks. And I do talk in the book about the failures in 1918 in the Woodrow Wilson administration to address that. Obviously, they didn't have the technology we have today and the ability to address these things. But even today, we are somewhat flummoxed by the lack of countermeasures. And I wrote in the book in 2016 that our flu plans are completely contingent on having a countermeasure for response, meaning an antiviral and or a vaccine, which we have for flu and we could rapidly develop and deploy for flu. However, I said in the book that we don't have this for coronavirus and we really need to develop it quickly. So I think the federal government has good plans, but they are only contingent on having the materials to be able to deploy during these periods. So that's one of the challenges we're facing now, recognizing that it's now past the situation where we could have developed it a few years ago. I believe that a vaccine is not really going to solve our problem in the short term, unfortunately, because it's going to take 12 to 18 months at best. But an antiviral is potentially possible within a more acceptable time frame, and perhaps even by the fall. And so that's what I'm pinning some hopes on there. Also, I think the shelter-in-place plan appears to be doing a good job of flattening the curve. However, I wonder about what the impact on the economy has been. We're going to have to figure out a way to understand the dynamic between those two things, because obviously there's dislocations and health impacts of the economic slowdown or economic potentially collapse. So I look forward to talking to all of you about how to mediate between these two challenging priorities and to figure out how to get the nation going again.
Thank you very much, Tevi. Of course, you can expand on your insights, and we plan to publish your insights again. Now, I would recommend that we go back to our panelists to see whether they have any additional comments at this point, and of course, to ask Professor Don Wallace to make any comments or ask any questions. So why don't we go back to Roberta maybe first, and Jim, then Charlie, and then forward.
Hi, it's Roberta. Can you hear me? Yeah.
Yes.
So, these were all fascinating presentations, and it's really particularly interesting for me because we've been so immersed in the medical aspect and the response preparedness aspect of this pandemic. So I really like hearing all the other perspectives. But one area that I think in particular has resonated with me is getting back to work and how this will affect our workforce, and also how this has affected just in general people's resiliency. So, and one of the other speakers, the orthopedic surgeon, also mentioned the issue of telemedicine and telehealth. So I have to tell you, we have been doing telehealth at Children's for at least 5 years on a significant volume. And in my division, infectious diseases, we actually had started to expand telehealth really so that we could provide access to people that live very far away, or in some cases even in other states, for our specialized expertise for things like Zika virus. But I have to say, even though there was this intent to move telehealth forward, there have been so many barriers, both with logistics of between state licenses and all sorts of administrative barriers, such that we could never really get it in the exponential phase of growth that we always wanted to. And I have to tell you, within 2 weeks of this pandemic really hitting and states having these closures and us putting in place ways to protect the rest of the hospital, there was an encouragement to move ahead with telehealth. And it's amazing how quickly all of these barriers just vanished. So, not that we are happy about this pandemic at all or that it's a good thing, but I do think it has shown, if there is this will, things can happen extremely quickly. And I don't have time to give you all the numbers, but you can look at our clinic volumes, of course, shrunk because we don't want our patients to be exposed that don't need to be in the hospital. But literally within 1 week, they were able to get 600 providers online doing telemedicine and converting those visits. And that just, we haven't been able to do it with that rapidity before something like this happened. So I'm really interested to see when we get back to normal, whenever that may be, and I don't think it'll be Easter, but when we are, quote, back to normal, how much of this extra telemedicine reach that we now clearly can, we've shown we can do this and do it well, how much of that will continue, or will we get all these restrictions put back upon them? And I also think the points about the people that are now getting used to having this other way of working, which honestly can be more effective than being in the office 12 hours a day, particularly if you're writing grants or publications, etc. How much of that we will retain when we get back to the new norm, whatever that is. So I'll be interested to hear other people's thoughts on that.
Thank you very much, Roberto. We'll move on to Jim.
Thanks, Yana. I think Roberta actually makes a really wonderful point. I mean, I'm not one to be a Pollyanna or necessarily look for silver linings where they don't exist. But in this case, you have to also take a look at what I'll call post-COVID culture and post-COVID environment. We are seeing a change in our carbon footprint. We are seeing a change in levels of pollution. We are seeing a change in the need and capabilities for socialization. And certainly we're probably going to see a change in the way we educate our students and the way we work. And those are not necessarily bad things. Once again, lessons learned, I think, are important, that there may necessarily not be any bad experiences per se, but experiences that we need to weather. And as a consequence, those experiences then become erudition. What's become, I think, important to understand is that even though we're now right of bang, there has been good mobilization of intent, and not only attention and intent, but certainly revision of certain regulatory barriers and parameters. And here, kudos need to go to the FDA, working with National Institutes of Health, CDC, and the DoD. Both Dr. Troy as well as Dan Gerstein made some interesting points with regard to the necessity for a preparedness stance that relies upon effective, efficient, and available testing. And Dan Gerstein and I have suggested that certainly there are certain regulations that need to be expedited so as to be able to move those types of testing into affordable, highly provisable, and very available and efficient means. Certainly things such as real-time PCR, as well as serological analysis, so as to be able to determine if and to what extent herd immunity is a variable, are going to be contributory in at least returning part of the population to a relative work environment for economic and social stabilization. As well, one of the things that Mr. Gerstein and I have suggested is a categorization of those individuals who are infected, those who are recovered, and they may represent viable entities of herd immunity, and those who remain vulnerable, and what rigorous protections as well as diagnostics, and in some cases therapeutics, need to be put into play. And those therapeutics are at least somewhat encouraging. I mean, I'm certainly encouraged by some of the rapid activity to remobilize the existing antivirals that have been suggested for other forms of coronaviruses, most notably the one that has been identified for Ebola. Again, not a coronavirus, but remdesivir seems to be particularly promising, at least in some patients. And accelerating trials, particularly trials that have a rescue component, as well as forced mobilization and protection in key domains, I think represent one of the variables that keep this slope from being a slippery slope. And my hope would be that we're able to move that forward in a more expeditious manner, and this occurs prior to fall, so that the 12 to 16 week window we're seeing of shelter in place can be mitigated at least to some extent by the availability of remdesivir treatment to those patients who may be early infected, those patients who may be infected but not necessarily symptomatic, and also evaluating the use of remdesivir to then prevent what might be a post-infectious syndrome. So I think each and all of these things bear particular witness to what I would call hopeful potential trajectories. And again, being a pragmatist, my hope is that these will then be weighed prudently and that lessons learned here will be lessons taken forward. Thanks.
Thank you, Jim. We'll move on to Charlie Ray, please.
All right, thank you. Yeah, in addition to what I said about revitalizing our diplomatic capability, I think one of the things that's going to be essential in light of the experience we're having now is we're going to have to, I think, take a new look at the way we conduct diplomacy, particularly in situations like this. We're always going to need professional diplomats, but we need to equip them to be better able to communicate and do their jobs in cases where they might not have the mobility that you would have in normal times. And that's going to take not only support from the political leadership in the Congress, but a sort of a cultural mindset change in the diplomatic service itself. And those are things that really need to be on the table for discussion among those who are involved with building and maintaining our diplomatic capability.
Thank you very much, Charlie. For drawing.
There, the audio's on. I just wanted to say how much I've learned from listening to you folks. It's been very helpful. And I really hope that out of all of this, there'll be a renewed effort to try to do what we haven't done well in the past, which is take the lessons learned and actually implement some of the new structures that need to be created and some of the new attitudes that need to be created, and help not just in government. I think that's important, very important, but also in the private sector. And I mean, internationally as well, because as was noted earlier, it's global trade and it's a global problem and it's something we need to confront. And I quite agree with the idea that training people to do these kinds of things will require a psychological understanding that in the past was not required for people in, for example, diplomacy. In the conflict resolution work that I've done, one of the things I found is that very often, whenever the feelings get expressed in negotiations, try to get away from feelings and instead talk about interests. And that's, you know, I studied at the program of negotiation at Harvard, MIT, and I understand that. We do want to be interested in real interest as well as the way people feel. But almost all the ones that are intractable because the feelings are so awful and so vital to understanding. For example, the transmission of trauma across generations is one of the factors that has greatly complicated life in the current world. And we don't think about it. I mean, remember when George Bush mentioned crusade after 9/11? That sounds, when Muslims hear that brings back centuries of crusade stuff. And we need to think about the psychological dynamic as well and understand it and try to incorporate it and not just say, well, that's a problem for the shrinks to worry about. It's a problem for all of us to worry about.
Yona?
Thank you. Yes, Don Reynolds.
I agree with Ford that I've learned a great deal, and it's been really a magnificent panel. However, I am left with a question. Let us say that WHO was perfect. Let us say that the Pandemic Directorate in the National Security Council was not eliminated or combined with another directorate. Let us say that we had reasonably substantial stockpiles. I don't see how we could have realistically prevented what has happened. Once it burst, we certainly did not control the food markets in Wuhan. And so everything is said is true. I think and of course I think the popular reaction is universal, that we're beginning to cope, but belatedly. But let's say we've been right on the button. WHO is perfect. That's of course is a fiction. Let us say we had John Bolton's not dissolving that directorate. Let us say we had reasonable stockpiles, I don't know, of ventilators or masks, whatever. I don't see how that could have realistically prevented what is happening now. We might have different moods. Let us say that our president was more careful in what he said. I don't think that helps, but I don't think the fact that if he were not there, if let's say Mike Pence were running these briefings, I think he does well, and Dr. Fauci was there, I just don't see how we could have prevented this thing from the beginning.
I do. Let me comment, if I may. I think all the points that you've made are accurate and important points. However, I think the key point that you made was the disbanding of a federal infrastructure that allowed for the level of surveillance to see this on the horizon of plausibility and the horizon of very, very strong probability. Clearly, in identifying that coronaviruses are a highly mutable and a highly adaptable RNA viruses that are capable of combination, recognizing that there are, in fact, vulnerabilities that are caused by climate change, intrusion into ecologies, and as you well mentioned, you can't control what happens in certain open air markets in a variety of different countries because those cultures may need to be preserved near their values. But understanding that those are possible nexus and those are vectors by which these things could occur, and then also understanding the growing potential threat, for example, of things like gene editing, the variety of mobilizations that can occur as a consequence of these things. And again, this is not to say at all this is a bioweapon at all, but what this then does is they open this door to possibility, exploring those possibilities early on, and then recognizing the if-then. If this were to occur, then what would be the probability and the possibility for these things occurring in potentiality? And what types of stopgaps would need to be in place to then mitigate probability or mitigate the probability from going to particular possibilities that would then be devastating? So in this particular case, I think that our evidence in terms of the fact that certain antivirals may be effective, not against all particular cases, because there's going to be phenotypic variation in how people respond, but that antivirals may be effective against certain entities of this virus, and then developing the resources to then rapidly mobilize and perhaps revise those antivirals so as to meet the molecular structures could be done early on, mobilizing the biomedical community in concert with the commercial enterprise, in concert with the federal government, to be able to guide regulation so that things are now reviewed as investigational novel drugs for humanitarian use exemption, put into place particular provisions where often drug statutes don't need to be readdressed, but then can be waived very, very quickly. I think we could have been able to divert this earlier, and I think to the extent. But again, the idea of an early warning system and a biothreat response system was not in place. So the point that you well made with regard to if this had happened, if that had happened, I think those were dominoes that perhaps individually may have prevented the entirety of the domino chain. And when taken in sum, learn as lessons learned.
Thank you. Are there any other comments related to Professor Wallace's question from the panel or the commentator? At any rate, sorry, go ahead.
Yeah, I would proffer this for what Professor Wallace just said. I'm not sure that there would have been a great deal of change in terms of how the virus will infect people. However, I think with better preparation, there would be indeed a better psychological response, and I think there would be less panic. I think with less panic, I think people would be able to be mobilized, and they would actually be more participating in correct ways of management. I think that you wouldn't see thousands of kids on the beaches during spring break. Perhaps Mardi Gras might have been different. I think the public response would probably have been different, and that may have had some impact, or could have contributed to a positive impact at reduction of the curve quicker.
If I may, let me comment to that, please, just very briefly. I alluded to something called the 2010 NATO Moldova exercise. And what we were tasked with doing was doing a red, white, and blue game exercise, essentially a war game looking at a bioagent. And again, as I had mentioned during my time at the mic, if you will, the nature of that was an agent that affected the neurocognitive system. But that wasn't the real, quote, virus, if you will. The real virus was viral information and misinformation that was then propagated through a variety of both social media as well as infused media, infected media, if you will. Truly propaganda and or fake news, true fake news, where you then insert fake information in a misinformational campaign so as to disrupt the fiduciary that exists between the public or the polis and the politics on a variety of levels, public health as well as resources on local, state, and regional government. So you're absolutely right. I think that certainly the parameters of the virus itself, the biological parameters of the virus may be patent. That would be the natural history of the disorder. The ability to then identify certain therapeutics, interventions, and things that might be necessary to flatten out the curve early on with appropriate information would have been the key to affect the psychosocial changes that are necessary to mitigate on a biological level the natural history of the disorder. So yes, I certainly agree with what Dr. Ratha said.
I have a question.
Now, I see your name, but not your face, but I know you, so. Please go on, Milton, go on, and that's it. That'll be the last question.
I was going to bring something to your attention. The G20 is having a virtual meeting right now to discuss international cooperation in connection with the coronavirus. And I think this is very important. First of all, the meeting was not brought together by the United States. It was brought together by Saudi Arabia, of all countries. And they're meeting together to discuss things like, improving supply chains, dropping tariffs, maybe even sanctions in some cases. I think this meeting, which is ongoing right now, is something that is very important in the diplomatic sense, and I want to bring it to your attention because there is so little actually of international cooperation in this whole endeavor. I'm glad to see that Jim Giordano mentioned that at the end, but still, I would bring your attention to this meeting of the G20. So I'll be quiet after that. I had many other questions, but it's much too late.
Yona, with your permission, I think we probably should end this program. I think it's been an excellent program, really a tremendous panel. I hope we continue this work, Yona. And again, thank you all. All of you take care, keep your distance. I hope you've got lots of wipes, gloves, et cetera, and so forth. Anyway, thank you again, Yona. And Ford, it was nice seeing you.
Great to see you. Thank you.
Thank you.
Bye-bye.
Everybody.